All right, ladies and gentlemen, thank you all very much for joining us today. This is our 2 o'clock meeting of the Health and Hospital Committee for Santa Clara County. And first item of business as we call the meeting to order is to ask the clerk to call the roll and establish the presence of a quorum.
Supervisor Ellenberg?
Here.
And Supervisor Smitty?
Here.
Thank you. You have a quorum.
Thank you. That's a good start. That takes us to item number 2, which is public comment. That's the portion of our agenda set aside for comment by members of the public on non-agendized items properly within the jurisdiction of our board, or in this case of our committee. I have a card from Scott Largent, who I will invite on up. And then I do have a card from Leonard Williams. Is it also for public comment? Leonard Williams? Well, we'll see. Mr. Largent, come on up, please, sir. And go right ahead.
Reverend, you are, David. Thank you. Thank you. Good afternoon, everyone. I've been calling a visitation place at our courts. This is actually one that's grant funded. A little frustrated this morning. I've now left them about 7 messages, no call back. So even though it's grant funded, I'm surprised this is kind of the same get down that I've been going through. I went through that also with I guess it's a nonprofit, Catholic Charity Services of Santa Clara County. Now, I went through this for about 9 months, and I've explained to everybody the begging, the pleading, saying needed visitation, I can't afford it, you know, blah, blah, blah. That was 9 months. We've now gone full circle, and the county's trying to help me again, but we're back to the same thing again. So, and I'm not meaning to throw you under the bus, Tony, but the Catholic Charity Services thing has bombed again. So today is my little girl's 4th birthday. It has now been 3 months since I've seen her. It's very hard on me. And I won't get to see her today. I kind of know that. And you got to be strong about things like that. And you all know it's eating me alive. But at what point do we start providing just a path to be able to be in our children's lives if we do the right thing in Santa Clara County? I've been in recovery now for 3.5 years, okay? I have no criminal record now, okay? Drug diversion, slap on the wrist. I have done it all, but I'm wondering at what point does the right hand talk to the left hand? At what point do all these departments start getting together and realizing, wow, how did this guy manage to slip through the cracks? How did he manage to complete all this stuff here that he was told to do to be in his kid's life? I mean, this is one thing after another. Drug testing, classes, you know, paid for the visitation. I mean, I have thousands of pages like this. You people are not paying attention. You're not. At what point do we do more for people? And I see no success stories out of Santa Clara County for people getting off of drugs. I'm not seeing them. I understand they're all on meth. I'm down there filming all of them right now because I have a heart and I want to get them clean. And I'm tired of watching people die on our streets. Start producing success stories. Start paying attention to all this. This is easily accessible. How many times have I been here? How many times have I begged? You all could learn so much from this right now. You could find out how I felt right in the middle of that donut right there. And we don't want that to happen anymore here in Santa Clara County. And I'm not going to let it happen under my watch. And I love my daughter to death. I absolutely do. I wish I could sing her happy birthday. Make it happen. Thank you.
And I believe our next speaker is Leonard Williams. Welcome, sir.
Hi, I'm Leonard Williams, and I'm on the Patient Family Advisory Team I'm from East Valley, but I represented all the teams. What I'm here today to talk about is basically East Valley. We work hard all over, and all our facilities look great. I mean, they're all painted, all nice and everything. You take a run out to East Valley and you look at that building, it's black in all colors. It looks like mold coming through the walls the way it looks. I've been working very hard on this. I've been working hard on, I don't know if any of you know where Ludlow is at. I'm sure you do. That is going to be torn up and repaved this year. I've been working with the City Hall on that one. So what I'd like to see is some kind of commitment that this year, some hopefully, that we could get that building cleaned, power washed and repainted. Because it looks bad, and our patients even say, you know what, we have a beautiful facility here. We have great doctors, great nurses, great staff. We've been working real hard. We're building up our own volunteer system. We're really working hard to get volunteers. Our PFAC committee is going great. We're getting a lot of support from Benita and the rest of the group and from all of you. So what I'd like to see is some kind of commitment this year. Get back with me, whoever you can, and let me know, is this going to be done this year, next year, or what? I know the paving is this year because I fought and they were going to do it next year. I just got a call from the representative from District 6, and he said they are going to repave Ludlow this year. So if we could get that building power washed and painted this year. We already did the health building in the back. I don't know why we didn't do the front, but hopefully we can get it done again. Thank you for your time.
Thank you. Before you step away, is there someone on staff that can, I see Mr. Lorenz saying he will work with his staff to get the information back to you. Thank you. I want to confirm with the clerk, we have no other cards under public comment. We do not. All right, that takes us to item number 3, which is to approve the consent calendar. But before we do that, Supervisor Ellenberg, without objection, let me just ask, do we have folks who are here to speak on item 9, which involves the sunshining of 4 budget inventory items? Okay, we do not at the moment. I will get to them in their proper place on the agenda. I just wanted to make sure we weren't keeping folks who just came to the chambers to testify briefly, but it doesn't look like that's the case. So if we can get a motion to approve the consent calendar as contained in our published agenda. We have a motion by Supervisor Ellenberg and a second by myself. So without objection, so ordered, the consent calendar is adopted. That takes us to item number 4, which is where we consider recommendations relating to the medical staff. And so we'll turn to you and ask you to introduce yourselves for the record, even though we know who you are. And then please go ahead and share your report.
Good afternoon, Supervisors Smidian and Ellenberg and the Board of Supervisors. My name is Yvonne Karanis. I am the president of the Enterprise Medical Staff. I'm here to present the credentials report and answer any questions, as well as the nurse practitioner privileges in adult neurology.
Thank you. In the absence of any questions, we don't have any speaker cards on this item. In the absence of any questions, just a motion to approve the appointments and reappointments and privileging actions of the staff as presented would be appropriate, and also to approve the criteria for the nurse practitioner privileges in adult neurology. Yes?
Yes, please.
Okay. We have a motion by Ellenberg and a second by Simidian. Comments? All right, then we'll say without objection, so ordered. Clearly, you made a very talented presentation, so well done. Thank you.
Appreciate that.
David, if we could turn the volume up just a little bit for folks who are speaking from that mic, it would be helpful and appreciated. Thank you. All right, that takes us to the next 2 items, which are going to be content-laden and require a little time. So I am mindful, Dr. Smith, I think you have to leave the chambers at 4 o'clock, so we're going to work with that in mind. But I do want to start with item number 5, which is to receive the report from the Public Health Department relating to countywide health assessment. And so, Dr. Cody, do I turn to you to begin?
Yes, thank you, Supervisor Simidian. I'm Dr. Sarah Cody, County Health Officer, and I'll start the report and then pass it to Pam Stoddard, who's our Director of Research and Evaluation for the department, and Rocio Luna, our Deputy Director, who can also help field questions. First slide. So today, just to give you a roadmap of what we want to talk about, we wanted to present on our role providing countywide population health assessment. And I'll just start with describing the distinct role that local health departments in California have, then our role performing health assessments, highlight some gaps that we have that we wanted you to be aware of, and discuss some opportunities and where we go from here. So as you may know, next slide, local health departments play a unique role in public health, and a lot of public health happens at the state and local level. In California, the structure that we have is quite decentralized, where most of, quite a bit of responsibility and authority is pushed out to counties. And that's where a lot of the work happens. The state's role in our state is primarily to provide guidance, resources, technical assistance, help with troubleshooting, and they also provide statewide systems, for example, for statewide surveillance systems. This is a slide that I hope will just frame everything that we're going to talk about from here. And we were debating about how to describe our upstream, downstream work. We have many more graphics we could share if you're interested in this. But essentially, what I wanted to share was that the work that we do in public health is really focused upstream. What are the activities and tactics that we can employ to have a community-wide impact? So to take, whereas as compared to other activities that happen in our county and in our health and hospital system and elsewhere that are more what we would describe as midstream or downstream work, to give an example of what this means, for example, in diabetes work, the public health department, we're thinking about how do we make interventions in the community such as reduce consumption of sugar-sweetened beverages, change the environment such that people can get more exercise, et cetera, as a way to prevent diabetes. Whereas a midstream activity in our county would be in whole person care, where we're screening individuals for social needs, housing, transportation, access to food, et cetera, that might help them manage or prevent diabetes. And finally, in our delivery system, the care of individuals with diabetes, where we might implement screening to identify people with diabetes or screening for health conditions that might make someone at risk of complications from diabetes. This is another slide, and I won't walk through it in detail, but again, just to give you a framework for how we think about our work in public health. This was developed by the Bay Area Regional Health and Equities Initiative, also known as BARHI. It's a model that's used across the Bay Area, and there's actually been significant uptake across the country within a number of local health departments. And it essentially shows the upstream, downstream framework in a different way. Where on the right, you see downstream activities. This was more the previously the traditional role of public health, where we are engaged in a lot of health education and individual case management. It's work that we still do, as well as we're moving upstream to focus on community capacity building, strategic partnerships, and thinking about the underlying social inequities that underlie disparities in health outcomes. Next slide. I wanted to give you a glimpse of some real data from our county. This is life expectancy at birth by census tract, just to give you a sense that when we're looking at the health of our population, we look across. This is a very basic measure, how long do people live, and you can see that it varies significantly by place. And there are areas in our county where there's a concentration of people who are not living as long as other people, and you can imagine that there's many different factors that underlie this. Next slide. So before I pass it off to Pam, this is just to show you the three core functions of public health: assessment, assurance, and policy development. And today, where we're going to focus is here in assessment. One of our core essential services is to monitor health, and so that's the countywide health assessment. And Dr. Pam Stoddard is going to take the presentation from here and show you a little bit about how we monitor the countywide health. Pam.
So thank you, Sarah. And first we thought we'd start with the reason why countywide health assessment is a core function of public health departments in particular. And this has to do with our role as a public health authority. This authority means we're responsible for public health matters as part of our official mandate. And under this authority, the health officer can mandate reporting of certain kinds of conditions. Most of them are infectious disease from healthcare providers. And even when reporting is not required, healthcare providers can voluntarily provide information to the health department to help us carry out the public health mission. So we have this sort of unique role relative to reporting of conditions. We're also
Excuse the interruption. I think you're coming through loud and clear, but if you would pull the mic just more in front of your mouth, directly there, and then speak, I think it will do even better. Thank you.
All right.
Thank you.
All
Sorry
right,
for
I'll
the
lean
interruption.
forward a little bit.
There you
too.
go.
Okay. So we're also able to coordinate with the other public health authorities at the state and the federal level. We have that unique role. Our mandate means that we have authority and responsibility countywide. So we take a countywide perspective relative to health assessment, whereas other stakeholders may be more interested in monitoring the health of a particular subpopulation that they serve or they belong to, for example. And for all these reasons, we have access to restricted data at a countywide level. So that sort of uniquely positions the public health department to do countywide health assessment and why it's one of our core functions. Next slide. So we also wanted to start off by providing just a little information on health status to help frame the discussion of gaps and opportunities around assessment. So this slide is actually a slide for the U.S., but we wanted to give you a big picture sense of the shift in the causes of mortality since the beginning of the last century, from where infectious diseases and chronic diseases were very similar in terms of mortality rates. But since then, as you can see, there's been a steep decline in infectious diseases, like TB, which were major causes of death, towards chronic diseases, which are declining as well, which is very good news, but they're by far and away the most common cause of mortality at this point. And the reasons for the shift that we see does have to do with public health interventions as well as advances in medical care. In terms of the county itself, these are the leading causes of death in the county last year. So as with elsewhere in the U.S., the top 8 of the top 10 causes are chronic conditions. There is still influenza and pneumonia, so infectious disease still do feature, as well as unintentional injuries. And cancer and heart diseases alone accounted for nearly half of the deaths in the county last year. So the shift from infectious towards chronic disease is important in understanding the infrastructure around the countywide health assessment that we do. So that infrastructure really grew up around this role of controlling and preventing infectious disease. So mandatory reporting regulations, for example, were put in place. State and federal electronic reporting systems grew up around it. Whereas for chronic disease, and we'll talk a little bit about environmental health assessment, there's more limited infrastructure. So there isn't any mandatory reporting at this time. The data are in a patchwork of systems. A lot of them are clinical that we don't have access to, and so we tend to rely on self-reports to do a lot of our assessment of these kinds of conditions through surveys. And here's some of the examples of the countywide health assessment that we've done over the last several years. So we do regular reports on the county as a whole, and we've also generated some in-depth health assessments on subpopulations and at the request of community members in the board, which you might be most familiar with. And these tend to be broad-based. So in terms of how we do assessment, we provide data that span all kinds of conditions: chronic, infectious, mental health, health behaviors, injury and violence, and we break them down as much as we can by things like age, gender, race, ethnicity, country of birth, things like that. But we also do assessment for specific conditions. HIV is a good example of this, where we go in more in depth in terms of populations at risk, the trends, contributing risk factors, things like that, as well as incidents where we can report it, which is the number of cases in a given time period. So to be most effective, countywide health assessment has to be responsive to the communities that are affected, because we need to give them data that they can act on, usually in partnership with the department, but not always. Community partners are more likely to take action if they're involved in the assessment, so we take a participatory approach. And we've all involved a spectrum of partners that you can see here. And they participate first through providing data, a lot of times, through answering surveys and things like that. And then they also participate through short and long-term coalitions, councils, advisory groups, things like that. So in addition to these kind of broad-based and assessments involving community partners, we also provide assessment to specific partners for planning processes, and we can give some examples of that. So that's sort of outside of the more broad-based assessments. Here's a sense of how data are used. All the way from planning to advocacy, policy making and grants, through funding allocation, monitoring trends, and evaluation. So we're going to pause, go a little bit slower on the next couple slides, because this is really the challenge that we're facing. We wanted to bring to you today that we're facing with countywide health assessment. So we do, I think, a pretty good job in terms of the data that we have available to us and engaging our partners, making sure it's responsive to their needs and meets their needs, and helping them with planning for priorities. What we struggle with is gaps that we have, and there are data out there to fill these gaps, but we wanted to first talk a little bit about what these gaps are to give you a sense of the issue. So the first is data lag. So there's a lag in some of the data sets we get, sometimes up to 2 or 3 years. It has to do with processing. And some data are only available on an annual basis. And so that means we don't have the data, the most current data, always available for planning. We can't quickly identify emerging issues, and also if the lag sometimes means that our partners will reject the data as too outdated, and that could mean that there's no public health action taken at all on some issues. So that's a real problem. In terms of precision, this has to do with our need to rely on survey data, which is self-reported. So that's fine for some things like health behaviors that are only the individual would know about. But for topics like disease diagnosis or screening, it's better to get the actual diagnosis from records or lab tests, because people might not remember their diagnosis. They may not remember if they've been screened, for example. So we can't provide information that is as precise as we would like to when it comes to health assessment. Next, the next challenge for us in terms of data gaps is small populations and also small areas. That's the next one, Amy. So the Santa Clara County, of course, is one of the most diverse counties in the nation. We can't look at the health status of the county as a whole for this reason. It would mask disparities between groups and doesn't provide people the information that they need to act on. So when we have to rely on things like surveys, which are based on small numbers, we really can't break it down the way that the data should be broken down to provide data on small areas and populations. And also want to mention that the demand for this is growing. Also, surveys are expensive. We can't collect them very often, and other data are only available infrequently, and so really limits our ability to monitor trends, make mid-course corrections, and monitor effectiveness. And then finally, the data that we have are not as comprehensive as we would like, so we have real gaps in terms of some health conditions we can't monitor at all. We can't look at things like progression, generally can't look at anything in detail in terms of cost, whether or not those affected are connected to care. So we have a real gap in terms of comprehensiveness. So this slide is an illustration. We thought we would use diabetes as an illustration of the gaps that we face when it comes to countywide health assessment. So across the top are the things that you'd want to measure when it comes to diabetes, and looking at what leads up to it from a prevention standpoint. And down the left side are some of the things that you would want to be able to measure. So things like prevalence, which is the level of any of these things in the population. Incidence, which is the number of new cases in a given period. Who's affected, where they live, what does it cost, and some of the things we talked about on the last slide. So the green dots are the ones where we have sufficient data countywide to take a look at these. The yellow means we can provide limited data countywide, and red is where we really can't provide anything reliable at all. So it's not to point out any one gap, but just the idea that there are data out there that can fill these gaps, which we'll talk a little bit more about. And this picture would look a lot different if we were able to access it. Another illustration is for small and hard to reach populations. I think, again, with the diversity of our population, it means that because we're unable to break this down, when we get things like requests for health assessments from the community for a specific target group, we have to rely on surveys sometimes, but response rates are declining. We don't have access to clinical care that could help us more quickly produce some of these health assessments. And so we're relying on things that can't be trended over time, like qualitative data. And the results of that are insufficient data for advocacy, potentially, and potentially inequitable resource allocation, as well as other implications. In terms of environmental health assessment, these are some of the measures that we would like to have that we don't have access to now. increasingly there's going to be an interest and demand for information about the health impacts of climate change. So we're limited there in terms of what we can do with the data we have available. And also the impacts of other environmental concerns that we'd like to do more assessment of, like lead, mercury, pesticides, and other toxins, the health impacts of those. We have some data, but it's limited. And then finally, there are fewer gaps in our infrastructure for infectious disease surveillance, but we do have gaps. For example, there are delays in or lack of reporting of some acute infectious diseases. And then because the system was really set up for acute conditions, we don't know the prevalence of many chronic infectious conditions, and those are things like latent TB and chronic Hep B. So where the conditions are chronic, they require monitoring over time, and we don't have the information we need to create the registries that we need to monitor them. And then monitoring aside, we don't get the medical history that we need for fully for control. So for example, if whether or not a person was vaccinated, they may not remember. So we do a lot of kind of manual calling around to figure that out, to call their clinicians. And then finally, the reports that we get on acute infectious conditions don't come with social information for things like travel or homelessness that might be in electronic health records, and that means it's hard for us to prioritize. So if there was a case where the individual was homeless, that would be the highest priority, and we don't have that information. It's a little bit of guesswork. So these are gaps that could be filled with data that are out there, particularly from clinical and claims records, and that would really vastly improve our ability to do assessment around infectious disease. So we see an opportunity to address these gaps in improving our infrastructure to receive data, and we're currently piloting that. It's called the Public Health Vault, and it's in conjunction with the Whole Person Care Initiative, and we'd like to thank the leadership of the initiative for their support of this pilot. So the pilot phase is underway. We decided to start with data from HealthLink and from VHP claims in our own system. And diabetes was selected as, we're doing it a use case by use case. We selected diabetes because of its role in T2020. So the two systems were already working on this in collaboration in terms of diabetes prevention. In the longer term, we plan to work with other healthcare systems to receive data for diabetes and for other use cases, and then we hope to add social and environmental data and match it with records, which will enable us to fill in these gaps and see where to intervene. So going back to the gaps that I discussed, if we were able to do this, we would have less lag, more precision. We could tell who's most affected, including small communities. We would have the data to look at things more frequently and more comprehensively. So this would enable us at a department level to be more effective. And at the county level, we'd be able to provide county agencies, when they're making decisions, more information about the health impacts so that they could make better decisions. And then in terms of our other partners, they also, I think, would benefit from those same two things, but also have better data to advocate for themselves and to mobilize their constituents around health and addressing health disparities. So thank you very much for your interest, and we're happy to take any questions.
Thank you very much. Supervisor Ellenberg, I see you reaching for your button. Comments, questions?
Thank you. Thank you very much, both of you, for that presentation. I have a number of questions. First, starting with some of the specific pieces that were in your presentation. We are so data-driven as a county. I'm actually surprised at the silos, and I'm curious to know, perhaps from Dr. Smith or others, what our process is toward working toward integrating the health data across all systems, including public health.
I think we'll leave that with Renee.
All right.
Yes, and in that particular case, obviously, different departments are operating under different regulatory frameworks, and that's the kind of complexity that we have. If you could think of it as not only the infrastructure, but different regulations and rules governing the conduct of how to handle data and information within each of the departments. So it's not solely the way we're organized, but then also we're very constricted in terms of sharing some of that information. We have made strides, obviously, as indicated on the whole person care with the Vault, to be able to share at least one directional flows to public health. So public health becomes a repository of the information for some very specific limited basis. And we're working also with TSS to build kind of an overlay of an infrastructure that will ensure the privacy and security concerns that both individuals as well as departments might have about sharing data, so that we can do that safely and securely. And then, of course, the goal is to be able to do that continuously so that the data is flowing to the appropriate and for the appropriate uses. So I think that's something that we're going to have to work on for a while, but we have to overcome a lot of regulatory barriers to do that.
So I would presume that the data that public health is asking for, they are aware that it is proper and appropriate. So do we have a time frame for working that through? And the reason that I'm pushing that a little bit is that I actually spent the morning at the Healthier Kids Symposium, and was thinking a lot about where we emphasize and where we budget dollars for disease treatment as opposed to prevention. And I see the public health department as being a huge tool in our arsenal to really work on prevention. And I think, and I don't think we're unique in this way, but as a county focused very much on treating existing diseases. And I would like to see us really work actively toward being able to empower our public health department to really work on that other side, clearly, so there are fewer people to treat on your end. So is there a time frame? We know what the regulation limitations are. We know what they would be allowed to access.
Well, what we could do is we give you a general overall guidance in terms of our approach. It's not a specific time frame in terms of actions and tasks, because it's again, some of these things we have to overcome some federal, state regulatory requirements. But I think what we can offer you is a general guidance in terms of our goals and how do we actually go about sharing this information. Our shared vision of better health for all is rooted in exactly what you're saying, which is we need to know not only at the individual level, but then also at the group and the community level, what exactly it's impacting their health, whether it be from the good perspective in terms of protective factors as well as risk factors. And so I think it's very, we can deliver something like that in terms of response for you off agenda.
Maybe not even necessarily off agenda with the with the report that we get each month. And I have made this ask a couple of times, and I'll do it again when we get to that item. But I would really like to have the updates monthly from public health, from custody health, from all of the departments underneath your direction. I think will allow us to monitor more carefully. And I have a specific question also about something that wasn't directly in there, but an issue that's important to me, and want to know where that is in the context of the public health department's work right now. And that's what are the primary mechanisms that the department is using to monitor maternal and child health outcomes, and what does the data show are key concerns for moms and babies in Santa Clara? That was kind of touched on maybe in part of one slide.
Right, and we have some slides we could show you if that would be helpful. We have some extra slides that we can show you on some of the things that we do monitor. So we have countywide processes where we look at these indicators kind of on an annual basis. And then we've done, of course, the child health assessment, which is a more deep dive. Right. And maternal child health is also included as a component in the other countywide health assessments that we do, as that makes sense. So we're always looking at maternal child outcomes as components of other health assessments. Does that make sense? So in addition, we also have a 5-year plan where we do a strategic plan for maternal child health, and there's a countywide assessment that's involved in that process as well. So it sort of has its own process. It's part of the countywide process, and it's part of any assessment we do for subpopulations.
And where does that sit in the department's priority list?
Well, we have a department that works on countywide health assessment on a regular basis, and it's on sort of a schedule. I'm not sure if that's, so we're on an annual schedule, and they get updated on an annual basis and provided to stakeholders, provided online on our open data portal, things like that. So it's not so much a matter of priorities as we regularly report on these outcomes as well as other outcomes as well.
Are the slides easily available?
Yeah, we can show you some of them. So these are some of the indicators that we monitor on a regular basis. So first one is congenital syphilis, which of course has been having an uptick on the infectious disease side. This is the birth rate by race ethnicity. So this is something that we monitor. Again, you can see trends over time, looking at what's going on with different populations. This can help with planning and things like that. The next is preterm births, which of course is an indicator that needs to be monitored carefully. And there's been quite a bit of focus on reducing some of the reasons for preterm births, and so we're seeing kind of an overall decline, including in some of our most at-risk populations, and a general decline over the last 10 years. This is low birth weight. It's also another carefully monitored indicator of the health of moms and babies in any jurisdiction. And this is broken down by race ethnicity. And you'll see that we have some disparities depending on the racial ethnic group that we could speak to if that's of interest. Infant mortality, again, is one of the leading indicators that you'd always look at in terms of maternal-child health. And in Santa Clara County, as in the rest of the U.S., there are some pretty serious disparities by race ethnicity, specifically for the African-American population. And the population is quite small, so it's a little hard to see the trends, so we combine it in these 3-year groups. But you can see there's sort of a general decline, and then we don't know too much about what's going on with that uptake, but it's sort of things that we monitor over time, and then there are programs and interventions designed to address this. I think that's, and teen birth. So teen birth is related to a lot of adverse birth outcomes, and so this is monitored, and these trends also reflect what's going on in the state as well as in the U.S., but we've seen just a really steep decline over the last 15 years. This is births to females who are ages 15 to 19. The highest, of course, is the Latino population, but their decline is steeper than the other groups, which is what you'd want to see. So I think this in particular is good news that we're seeing locally. I think that's the last one. That's just kind of a selection of some of the trends that we monitor on a regular basis, and then provide that to our maternal child health branch and our partners.
Thank you for that. The biggest outlier, of course, is the infant mortality rate for African-American babies. And rather than take more time now, I'd like to ask for an off-agenda report that would share with us what initiatives are being worked on right now, particularly with regard to Black infant mortality and health rates, what your work plan looks like over the year to address this issue, and where you would like to go in a perfect world. Thank you.
Thank you as well. Let me just raise 2 issues. Some of the issues I was going to address were addressed by Supervisor Ellenberg, so no need to repeat there. The first is I appreciated the reference, Santiago, on the issue of importance of privacy and data security, which is a longtime concern of mine. I'm sure people have heard it and heard it and heard it. I do want to just offer a cautionary note, and I know particularly because of the HIPAA requirements that we're always mindful of these issues, but I think there are times when people think that data has been anonymized, when in fact, given today's big data capacities, the ability to pull different data sets together, given small samples, relatively minor pieces of information can be personally identified more easily and more quickly than might readily be thought. So just if we could ask, as public health does its work and tries to pull this information together so that we have better data and larger data sets, and that those data sets will reveal more, I do, however, want to ask that we be sort of constantly asking ourselves, is the data sufficiently anonymized so that we really can be confident of the privacy of individuals? Either, as I say, because, with small data sets, we've got, you might have anonymized data that said, well, all we know about the person is they're a county supervisor and their last name's Armenian. Well, it kind of narrows it down pretty quickly, even though we haven't named who that individual is. I was thinking of some other attributes and decided not to use them. But But you get my point. By the same token, if we have data sets here, here, and here, what may seem sufficiently anonymized over here, when coupled with the information in those other data sets, could suddenly be quite revealing. So again, just as there. One of the things that intrigued me about the report was I'm going to describe it this way, these are my words, as a sort of the growing challenge of the work you do as we are obliged to shift more and more of our attention and resources to what I'll call chronic conditions. Because, if I look back over among the many different trends in healthcare over the last 20, 25 years, as we've got folks who are living longer and longer, fair enough, that's a good thing, we want that. On the other hand, it means that our healthcare system is now dealing with chronic conditions in a way that it did not a quarter of a century or certainly a half century ago, when we were more about acute care, for example, at the hospital than managing some of these chronic conditions. Could you talk a little bit more about how that affects your data challenges? Was the question clear? In other words, it seems to me we're looking now at sort of less and less specific incidents or events or cases, and more at larger populations who have chronic conditions over a longer period of time. I'm trying to get a sense for what the implications are for the work of public health. Am I getting closer? I'm getting a lot of looks that suggest to me maybe nobody knows what on earth it is I'm trying to ask.
So as you saw, the leading causes of death are chronic disease. If you looked at death, disease, and disability, you would see chronic diseases dominating the field. The work in public health, which as we described is upstream, is that if you looked at the root causes, like what's behind cardiovascular disease, cancer, and other chronic diseases, for a large number of them at the root is going to be tobacco and obesity, which is one of the reasons why a lot of the federal funding and a lot of the work of federal, state, and local agencies is around obesity prevention and tobacco prevention, because it underlies many of the chronic disease conditions. But if you go upstream from that, you're looking at the conditions in the community, environmental conditions, and social conditions, which is what many public health departments are now turning to addressing.
And therefore, I'm trying to discern the implications of that for the work we're doing here at the county.
Right. I think it's a way to frame and understand, why is the public health department doing some of the work we're doing? Why is the public health department invested in GARE, the Government Alliance for Racial Equity? What does that have to do with public health? Well, it very much has to do with public health. So what we want to do is to give the board a view into the work that we do, so that you understand why we're investing in what we're investing in, why we have the programs that we have. And I think that in many ways, understanding the work in infectious diseases, it's very easy. That's where I started, because I can really understand it. It's very clear that that's a local role to prevent the spread of communicable diseases. Nobody else does it. That's what we need to do. With chronic diseases, it's a much, much, much bigger party, because it's collaborations with everyone from a local planning commission to an ICU physician and everybody in between, in order to do a good job at addressing chronic diseases. It's much more complicated, and as Pam was describing, that's where we have our data gaps, because our surveillance systems weren't built for chronic diseases. And so we have to get different sorts of data to give us a good picture. Without a good picture, we're not going to be as precise about investing well where we need to.
Got it. Thank you. That's a helpful clarification and extrapolation of the earlier conversation. I don't have anything else. We don't have cards on this, as far as I know, from members of the public. Supervisor Ellenberg, motion to take the recommended action, which is simply to receive the report. Motion from Supervisor Ellenberg, second, and without objection. So ordered, and we'll say thank you very much. That takes us to item number 6, but before we do item number 6, let me just ask the question I asked earlier, mindful of the fact that we've got some folks who I think are really here for item number 9, which is our budget inventory items. If we have members of the public who are here who'd like to speak on any of the items under item number 9, before we begin what I anticipate is likely to be a pretty extended conversation on this next item, number 6, this would be the time for them to come forward. Let me turn to the clerk and say, do we have any cards for folks who want to speak on items number 9, the budget inventory items? Clerk is telling me no. My staff is pointing to a member of the public who's racing to get a card. Okay, you can fill the card out afterwards, Ms. Liu. Come on up. If you're the one person who's here, we'll take you now. And again, I'm trying to let people come and go about their business if they're here on these sunshined items that are under item number 9. Welcome.
Good afternoon, Supervisor Simidian and Supervisor Ellenberg. I'm Michelle Liu, CEO of the Health Trust. We have an inventory item before you today. We checked with your offices ahead of time. We did not foresee any questions, but if you have any, you know how to reach me, and we'd be happy to answer them. Thank you.
And for the record, before you walk away, we are talking about item 9.
B as in boy.
And this is for New Client Services and Operations Center at the Health Trust, yes?
Yes.
And we do have paper on that in our packet. And are there any questions, comments? Again, these are here to be sunshined per our process so that when they come to the board for as part of the budget exercise, they've already been surfaced. People are aware of them. Thank you for being here. We'll let you go back about your business.
Thank you.
Go keep us healthy, please. And we'll come back to item 9, as I say, at its regular place on the agenda when the time comes. All right, item number 6 is the ambulance contract amendment. I'm going to try and use the time, Supervisor Ellenberg, between now and 4, when I know Dr. Smith has to leave the chambers, to get inside this topic. And let me just indicate now my expectation and my personal preference, although there may be a motion, is simply to forward this to the full board without a recommendation when the time comes at 4, but with a whole lot more information out, and also with questions raised today to which we may want answers before we get to our board meeting next Tuesday. So, who'd like to do a brief opening presentation? Dr. Smith, go right ahead.
Yes, Mr. President, I'd like to give a little bit of a discussion of context, then turn it over to Chief Operating Officer Miguel Marquez, because he's been more intimately involved in the negotiations. So we're requesting a 7th amendment to the contract that we currently have between the local EMSA and AMR. The board should know and does that back in December of 2010, after an extensive RFP process, the board decided at that time to award a new EMS contract for emergency ambulance services to rural Metro, and that contract began July 1st, 2011. It was a 5-year contract with the option for 2 3-year extensions. We've lived through the 5 years and 1 extension. We've given notice to, it's now AMR, for the 3rd extension. What you've been asked to look at today is a modification of that contract to deal with some important issues that have changed over the last 8 years. Which Mr. Marquez will go into in some detail. The current contract expires July 1st, and the ongoing contract will not be an exclusive contract as previous contracts were, because state EMSA has decided to remove the antitrust immunity which we enjoyed previously. This contract is for only the exclusive operating area, which is operated by the county, which includes all of Santa Clara County with the exception of Palo Alto. Palo Alto was grandfathered in as its own exclusive operating area a number of years ago when state law was changed to create exclusive operating areas. The reason for exclusive operating areas is so that regional health services in the form of ambulance services and other EMS services can be coordinated in a regional manner, not on a city-by-city basis. Therefore, the county has the obligation to adopt rules, regulations, contracts, and communications and procedures to assure that that process happens efficiently and effectively. So with that, I will turn it over to Mr. Marquez, who has a summary of what this Seventh Amendment does and the changes it makes to the current contract.
Thank you, Dr. Smith. As Dr. Smith mentioned, the original contract is back from December of 2010, and I happened to be serving as county counsel to the county back then, and I have here is a 40-page original agreement along with many different exhibits and amendments to it. It's a very thick document, a very complicated document that I think over time has served the county well. Also, as Dr. Smith mentioned, that this agreement that's currently in place created an exclusive operating agreement for rural metro for most parts of the county, and that's again allowed because the state has antitrust immunity, which the state can extend to the local EMS agency, and for that reason the county was able to enter into this exclusive area agreement with rural metro as a result of the 2010 process. Subsequently, I was away from the county, but during a period of time, the contract was amended 6 different times to address any number of issues, and as Dr. Smith said, to extend the contract one time for an additional 3 years. Most recently, over the last couple of years, the state EMS authority, I'm going to call it CalEMSA, after reviewing the 6 amendments that had been entered into in the aggregate, felt that there were too many changes from the original proposal that had been made back in the 2010 timeframe. So what CalEMSA did is they revoked the antitrust immunity that they had granted to us, but they stayed the effective date of the revocation through June 30th of 2019. So what that effectively means that come July 1st of 2019, the antitrust immunity that had been granted to the county no longer is granted. It's been revoked. The reason the state did this is to allow us to conduct an RFP process to provide an extended or a different contract. In 2018, the county indeed conducted an RFP process, and during that RFP process, we did hear from the fire agencies a very strong desire to maintain the first responder fees. What the county did receive as a result of the 2018 RFP process is one proposal, and that proposal, unfortunately, was deemed to be non-responsive. The RFP had any number of requirements, and the proposal did not meet all of those requirements, and so it was deemed non-responsive. So along with considering whether we could conduct another RFP with success, we also embarked on a negotiation process with the incumbent provider, now AMR, because AMR acquired rural metro, to see if we could negotiate an agreement that met everyone's needs. The focus was on quality service, lowest cost, and reliability. Reliability was especially important with respect to the aging fleet of ambulances that were being used. And we also understood during this negotiation process that the fire chiefs would be interested in the same things as before, which we understood, or the same things we were, quality service, low cost, and reliability, but also a continuation of receiving their first responder fees. So with that brief background, I'd like to go over a brief PowerPoint presentation that highlights the main changes that would be brought by the 7th Amendment.
Thank you.
So as we look at this first slide, you'll see on the left-hand side of the slide that the current contract is exclusive only because we have that grant of immunity from the state. And you'll see in the second bullet point, although the administration has exercised the option to extend for another 3 years, and that's required to be done 60 days before the expiration of the contract, pursuant to the current contract, the current contract cannot be extended as is because CalEMSA has revoked its grant of antitrust immunity effective July 1st. So looking at the right-hand side, what the 7th Amendment does is it recognizes that this contract is now not exclusive, and that's something that the provider has agreed to and understands. Second, what that means sort of functionally is if another provider would want to enter the market, they would have to meet all of the capacity criteria and accept the conditions of the AMR contract in the county's determination. And so that would be a requirement of them participating in this market. And if that were to happen, the local EMS agency would then develop a plan for mutual deployment. Turning to the next slide, with respect to the first responder fees, on the left-hand side, you'll see that the current contract pays $5 million on an annual basis in first responder fees, and that gets adjusted over time for inflation. Payment is made to first responders only if they have an agreement with the county. On the right-hand side, you'll see the 7th Amendment still commits AMR to paying the first responders' fees, and those fees are increased over time. The second point is important. Unless and until there are valid agreements between AMR and the first responders, the fees would still be allocated and distributed as was previously done pursuant to the existing contract with the county. So in other words, they have a mechanism, a scheme to receive those first responder fees under the current contract that will remain unless and until they can enter into different agreements with AMR that presumably they won't enter into those agreements unless they can come up with something better. But if they feel they can't come up with something better, they can simply not agree and will default back to what's in the current contract. And finally, as I noted earlier, the first responder fee increase is linked to the CPI index for all urban consumers for the San Francisco, Oakland, and Hayward areas. Looking at the next slide, you see really the key component of the contract is the fees that are charged. You'll see on the left-hand side, our current rate is $1,710.12. That's our base rate. And you can see that compared to any number of jurisdictions that are near us. And we are currently the lowest, and I'd say by far with Palo Alto being second. What the 7th Amendment does on the right side is that as of July 1st, the rate would go up by 5%, and that brings the rate up to $1,795.63, which is, again, still lower than everybody else. The rate would then increase in the next 2 years, depending on CPI, a calculation that's in the 7th Amendment, and it has an upward cap. So it has a minimum increase of 3%, a maximum increase of 7.5%. And we thought we'd put, for illustrative purposes, what it would be if the worst-case scenario of 7.5% were to be implemented, and that would be in 2020. It would go up to $1,930. In 2021, it'd go up to $2,075. And again, with the exception of Palo Alto, that would still be the lowest of any of our neighboring jurisdictions except for Palo Alto. And that's, again, comparing our worst-case scenario in 2021 to the current rate structure for the other jurisdictions. Turning to the next slide, there's the issue of response times. The current contract says that arrival on the scene of an authorized first response unit shall not stop the response time clock unless the first responder is authorized to do so by the county. On the right-hand side, the 7th Amendment would change that to say arrival on the scene of a county-authorized ALS first responder, county-authorized quick response vehicle, and for the city of Sunnyvale or any other jurisdiction that's authorized by the county to have a quick response vehicle, or a county-authorized ALS ambulance shall stop. Here it says what we need it to say, which is shall stop the first responder response time clock. That's always been the intent, is to stop the first responder response time clock. The 7th Amendment that was uploaded into Minute Track for the board meeting before did not include the words first responder, and I think that caused some confusion. And I think people looked at the language and thought that it meant that it would stop the response time clock for the ambulance. But that's, was just inartful language in the contract. The intent was to stop the clock on the first responders, but not on the ambulance. So when we bring back the 7th Amendment to the board meeting on June 4th, I think is when it's coming back, we will have an amendment that will add the two words first responder in that provision of the 7th Amendment.
And forgive the interruption, something I rarely ever do. Mr. Wagner, you're here on behalf of AMR Rural Metro, yes? Yes, sir. Is that, I'm just going to ask you to come forward and ask one very quick question, then let you take your seat again. Thank you for being here. Is that your understanding of the meaning of the first responder stop the clock language?
Yes, sir. That was the intent.
Thank you very much. We'll get back to you, I promise. Thank you. Mr. Marquez?
Thank you.
Anything else?
And I think that's the end of the presentation. And with that, we're happy to answer any questions you may have.
Okay. Supervisor Ellenberg, we have just 2 cards, so what I'm going to do is invite those 2 folks up. But first, what I want to do is try and frame the conversation a little bit from my standpoint, understanding that Supervisor Ellenberg may have a different framework through which she's looking at this, but I think there are some process issues and concerns that I want to address in terms of how we ended up here today and where we're headed going forward. And then there are some substantive content questions that I've got about the merits of the contract, both with respect to how it affects our county organization, how it affects the 2 million people who live in our county, and how it affects the various partners that we work with in terms of first response out in the 15 different cities and towns and the other jurisdictions. There may be more, but so when I'm asking questions, as I say, I'm going to be looking at process issues, and then I'm going to be looking at content issues, and the content issues I'm going to be thinking, all right, how's this affecting our county? How is it affecting our constituents, the folks who are clients, if that's their patients, whichever is the proper term, and then how does it affect our partners? So why don't we go ahead and ask Tom Wagner to come up, followed by Robert Sapien, Chief Sapien, and we'll give you each a couple of minutes, and if there's more, and I suspect there will be, we can certainly have a more extended conversation simply by asking the supervisors to ask questions about issues they want to explore with you. Welcome again.
Perfect. Thank you. Good afternoon, Supervisor Smidian, Supervisor Ellenberg. We do not have a presentation today. I believe staff did a good job representing where we were, where we've been, and what our future and what we're looking towards the future. I'm really here today with your local management team as well, Deb Petrick and David Gallagher, to answer any questions you have about the current service or the future service and the direction that we see this going.
Great.
Thank you for your time.
Chief Sapien? We'll be back to you, Mr. Wagner, I promise.
Good afternoon. Thank you. Robert Sapien, Fire Chief, San Jose Fire Department. I'm here representing both the City of San Jose and the Santa Clara County Fire Chiefs Association. On behalf of the City of San Jose, I will just state for the record that the city's position was articulated in a letter dated May 24th, 2019 to the county executive, and I believe CC'd to the Board of Supervisors and County Council as well. On behalf of the Fire Chiefs Association, I will say that we share some process concerns, particularly about our critical role, that we believe we play a critical role as stakeholders in the emergency medical services system. We have some what we think are very serious operational controls. As I stated at the May 21st meeting, the fire departments here in the county provide all hazard emergency response, which means we are positioned or deployed to provide for fire protection, rescue, hazardous materials response, and literally any physical hazard that threatens our communities. And to have the county not have us present in conversations where our resources will be impacted by way of things like time on scene, commitment for events, is very troubling in that our deployment models are very sensitive to any type of change, and our time on scene is one factor, as I mentioned previously. If you multiply our call volume out by just a few minutes, we have 63,000 times that we go out annually per year in San Jose for emergency medical services. So any changes to that deployment model we find very serious. Lastly, some concern about the status and stability of our system in both the agenda.
I'm going to ask the clerk to stop the clock. Thank you. Chief, I'm going to say, what else would you like to say? Because I want to hear it.
Thank you. So in both the consequences of non-action for today's meeting and for the previous May 21st meeting, we're understanding that there seems to be a presumption that rural metro would not continue as the provider of ambulance services in the county. We need to know that as the essentially the safety net for the county, because we would be largely responsible for any contingencies, and one single vote of the Board of Supervisors that could take us down that path, we need to be prepared for that, as July 1 is not too far away.
Okay.
Thank you.
Thank you very much. I want to understand, and I appreciate, Ms. Marquez, here's a phrase I don't think I've ever uttered. The PowerPoint was very helpful. So thank you for that. It's not often that I feel like it's not often that I feel I can say that, but in this case, it really was a nice, crisp way of sort of drawing out what some of the key issues are here, so we can focus on them. I do want to go back on process, and ultimately we need to focus on how we go forward and what we're going to do. But I've got some concerns about how we got here. I want to make sure that it doesn't happen again. And I think part of the challenge in understanding this for me has been that, as I understand it, we have a unilateral right under the existing contract to extend for 3 years. Is that right, Mr. Marquez?
The current contract does provide an option to extend, again, with a 60-day notice. That extension, though, would be an extension of the existing exclusive agreement, and couldn't extend an agreement that would comport with the regulatory scheme we find ourselves in as a result of CalEMSA revoking our antitrust immunity.
So the challenge here is that the unilateral extension we might otherwise have given is effectively precluded by the fact that we are no longer in a position to honor other provisions of the contract, meaning the exclusive right. Is that the position that people are taking?
Yes, that's correct, and that's why item number 2 in the 7th Amendment is, it says the following subsection is added to the EMS agreement, and it's entitled non-exclusivity, and it's one of those notwithstanding anything else to the contrary, because this whole agreement is premised upon exclusive operating area. It says notwithstanding anything to the contrary, this agreement is now non-exclusive.
And then that begs the question for me. My understanding is that we said that we were exercising our right under the contract to give 60-day notice and extend for 3 years on April the 29th, which would have been 62, 63 days before the end of the contract. So I'm trying to understand how, on the one hand, we said we exercised our right to extend, but on the other hand, we've said we can't extend our right to extend because we're going to change the contract. Can you understand my confusion? Let's start there.
Yes, I think the intention was always to enter into the 7th Amendment to allow for the extension, but it's a procedural thing within the existing contract to give notice prior to 60 days. So that was sort of done as a formality to make sure that someone couldn't say, oh, you didn't meet the requirement of Section 2.2 of the contract. So we met that requirement by providing the notice, and now I think Dr. Smith used the word consummate, but we're sort of consummating the extension so that it's sort of valid and binding and goes through 2022 by entering into the 7th Amendment. And I think it's important to make the point that this 7th Amendment would almost make a bridge, because we can't extend beyond June 30th, 2022. That's the limit of this contract. In the interim, fairly soon, we'll have to do another RFP process, and go down that path unless we continue with non-exclusivity. And so this is a bridge to get us there, and we'll make a determination whether going through another lengthy, involved RFP process. I mentioned that we did one in 2018. I should have mentioned there, too, that on the evaluation committee were representatives from the fire agencies. So that's a more inclusive process. I also mentioned that I wasn't here for the 6 amendments that happened before.
me-
And I'm not sure who was involved in those, but on these, this is more.
I want to stay on this point until at least I get it, and which is something did or didn't happen on the 29th. Either we extended the contract or we couldn't extend the contract because we had a change in the contents of the contract. I mean, we can't have this one both ways. I got people in the community and I got people who are here saying, what happened? How did it happen? What was the process? And if somebody said, look, we're just going to extend it for 3 years and we have the right to do that, and the county executive has that right because it was delegated authority to him, then I understand that. If, on the other hand, the answer is no, you can't just extend it because there's a necessary amendment to the contract, then we didn't extend it. So I'm trying to figure out which it is, and it sounds to me like you're saying we did two things that are mutually exclusive. Let me turn to the county council and see if he can help. Mr. Williams, what's going on here?
Sure. Those are not mutually exclusive.
Because?
Because you can absolutely extend a contract, but need to amend a critical term of that contract in order for that contract to be able to continue to function without you being in breach.
Okay, so and forgive me, but I mean, it would have been helpful if this had all been explained in the 2-page memo we got at the board meeting a week and a half ago. But so the position of the county is, when we're trying to explain this to the public and our partners, we had the ability to extend unilaterally. We exercised the ability to extend unilaterally, but before the existing contract expired and our non-exclusive status kicked in, we were obliged then to amend the contract. Is that where we are?
Yes.
And then is the action that our board is ultimately going to be taking an amendment, an extension, or both?
It's an amendment.
Because we already have an agreement.
Correct.
Okay. So, and before I get to Dr. Smith, just because I want to understand this with the county council, so the argument is when somebody says, why is there a rate increase, which I'm about to get to on the substantive piece here in a minute, why is there a rate increase? The answer is we had to negotiate, we had to get a bilateral agreement, we had to come to some agreement with our provider here in order to ensure that we got another 3 years, because come July 1st, we're not going to be able to deliver on our part of the contract, which is the exclusive agreement. Is that, am I still tracking here?
That's correct.
Okay. So it will simply be an amendment because we've already gone ahead and extended, or the county executive's already gone ahead and extended, yes?
Yes.
Okay. Let me just say for the record that, and also because I'm going to make a suggestion at the end of this conversation, this is a conversation that is obviously a matter of community-wide concern. We've had vast amounts of conversation both as a board and in this committee prior to my taking over as chair. It has been much published about back in the day, particularly when there was controversy about the selection of the provider, the performance of the provider, and that's not to cast any aspersions, just so people understand. There was controversy. So to do all this without coming to the board or to the Health and Hospital Committee was, in my judgment, a mistake. And I want to make sure that mistake isn't perpetuated going forward. Similarly, to think that we could do that with a 2-page staff report at the last meeting was a mistake. And again, I want to make sure that that mistake is not perpetuated. Having said that, not having the kind of comparison that we had today in the, I'll say it again, wonderful PowerPoint, I want to be positive here, wonderful PowerPoint, not having that information available for the board to fully understand what the implications of the requested action were was a mistake that, again, I hope we won't make. And while there may have been engagement with and involvement by our community partners, including the 15 jurisdictions and the first responders during the RFP process, it's clear that they weren't engaged on this process and were taken by surprise. Now, I've been around long enough to know that if you get what you want, you think there was enough input, and if you don't get what you want, there was never enough input. I get that. But my assessment here is we really did miss the opportunity to be communicating effectively with the people who are our partners on this. I don't have any judgment about their sort of longer-term, larger issues about doing their own thing. In a way, that's to be determined. But in terms of process, I got a concern. And then, to add to all of that, my recollection is that many of the documents that we did get backing up the last board meeting agenda item didn't arrive until Sunday, which meant that on a matter that was highly complicated, where we had very little information to start, any of the backup information was literally available if you knew to look on the website on Sunday night a day before a board meeting. Again, not the way we should do our business and not the way I hope we do it in the future. So whatever we do as a full board and in this committee today, one of the things I'm going to do is I'm going to ask for quarterly reports and discussions, not consent calendar, in this committee over the next 3 years, both to talk about where we are on this contract, but also where we are in an RFP process. Because while I think our board was involved and knowledgeable in the way that it should be about the previous RFP effort, which ultimately did not produce a good result, I don't think that can be said of this process that got us to this place today. So that's my process pitch. Now, on content, there's still some questions I've got, substance. So here's my question for our staff, and if staff can't answer, I'm going to ask the AMR folks if they can help, and I'm also going to hope that we have. So there's a fee increase here, and I understand staff's position is, even with the fee increase, we're still looking at what is better than a competitive rate elsewhere. And just so everybody knows, that's a point I've been making for the last several years. Whenever there was a controversy, I'd say, gee, except for those 2 times where there was a late arrival threshold met, I think in my first year here back in 2013 in 2 zones, the folks have been arriving on time and our rates have been lower than comparable jurisdictions around the Bay Area. So I get that, but there is a rate increase here. And so my question is, I understand the percentages, how much money is it? So that when somebody asks us, how much more, Chief mentioned 63,000 responses just in San Jose's jurisdiction. So I'm trying to get a sense for how much money are we talking about that is coming out of the pockets of ratepayers, fee payers, constituents in Santa Clara County over the course of a given year with this change, and how much of a benefit is it to AMR Rural Metro? And, again, I understand they're in a profit-making business. That doesn't offend my sensibilities, but I would like to know what the dollar amounts are. Can anybody answer that question, or was it located somewhere in the materials that I just didn't see?
Can I
please
give it a try?
Yeah.
Could I give a try at the process thing, or do you want to talk first about
First, I'd just like to know
fees?
if there's an answer to the money, because let me come back to you on the process matters, Dr.
Fair
Smith,
enough.
because I want to get some of these content issues
Fair enough.
raised.
The issue of exactly gross amount will be very difficult to predict. We'll let Mr. Warner give us a guess, but I just would like to sort of set the stage for his numbers. One of the major reasons why this contract was so difficult to perform was because the population of patients changed dramatically over the last decade, so that a larger number of patients are Medi-Cal, Medicare, and uninsured. The Medi-Cal and Medicare patients, their rate is fixed by Medi-Cal and Medicare, so no matter what rates the board sets, the provider can only collect those fixed rates, and so the rate change is immaterial to them. The rate that is actually collected from the uninsured is virtually zero, so the rate change doesn't really affect them. The rate change does affect the population of patients who are covered by third-party payers, but that number is decreasing significantly, and also other third-party payers are following Medi-Cal and Medicare's example and limiting their exposure by creating a fixed rate. So when AMR comes up to give you an estimate, you'll have to understand that it's purely an estimate, and that we administratively came up with what we thought was a reasonable number based mostly on cost of living changes and the trying to keep the rates below surrounding jurisdictions. But I think AMR should give you a gross number of what they think their increased actual collections will be.
Mr. Wagner, if that's something you can help us with, I would certainly appreciate it.
Thank you. So given the short amount of time, I have an estimate that I pulled together. So Dr. Smith explained kind of the high level of how healthcare reimbursement is completed. So what we bill is not necessarily what we collect. So when you look at the the current and the proposed rates that you saw, and you discount those for the government payers or the folks that have no insurance, on average in Santa Clara, we collect about $750 per run. And so if you take 5% of that number, that shows you, so that's about $37 more per trip that we're anticipating collecting. I think it's also important to note that that 5% number came about because that is the increase that under the contract we've been receiving every July as part of the contract. So this just kept the current terms of those rate increases in place that the county administrator was able to provide as part of the contract.
So let me try the question this way, since I'm still struggling to get sort of a bottom line number from any source as to how much more will residents be paying and how much more will rural metro be receiving. I'm trying to understand the value of the contract. How many calls do you answer?
Doug, it's about billable transports, 60, 80, 81, about 81,000.
So if I take $37 and I multiply it by 81,000, should that give me a rough estimate?
It gets you an estimate.
So roughly $3 million according to my calculation.
Right.
Okay. Dr. Smith, does that sound to you like a plausible estimate at least?
Yes, that's plausible.
Okay. Could I ask that we get more information on the dollar amounts, both as to what people will be paying and what rural metro will be receiving for our board meeting on Tuesday, so that colleagues have that information as they consider this subject? Then,
sure.
One of the areas that we have had, staying on content for a minute, one of the areas that we've had a great deal of discussion about, Supervisor Ellenberg, that was at this committee prior to your being seated on the committee, was the issue of timely arrivals, both by AMR Rural Metro, but also by our first responders, and particularly San Jose Fire. And I worked with Mr. Sapien on that. I worked with Chief Diaz on that, who's now in Mountain View, who was back at San Jose at the time. And there were, of course, penalties, liquidated damages for failure to perform. And the question I have is, have there been, it looks to me like there have been changes in that regard to the liquidated damages provisions. And one of the changes is that there used to be a change for per call non-compliance, and that while we're now looking at a $250 per late call flat liquidated damages, that number used to, depending on the delay in time, escalate all the way up to a number as high as $15,000. Am I remembering that correctly?
I believe that's correct.
All right. So if you are an elected official worried about timely response for the people that you serve, or if you're a first responder worried about timely response for the people that you serve, I think you can understand that if there used to be a fee that went from $250 all the way up to $15,000 per late response, but that number is now a flat $250 fee, think the typical response from somebody is, it sounds like there isn't as much incentive to arrive on time as there used to be. And it used to be that since that was dependent on how late you were, that even if you were going to be a little bit late, you had some reason to hustle it up and get there on a timely basis, because the later it went, the more expensive it got. Now, once you're late, and there's no penalty really built into that liquidated damages scheme to make sure that you get there as quickly as possible, even though you're going to be late. So in two very clear ways, $250 versus $15,000, and rising as opposed to flat, it sounds like there's less incentive to get there on time. Am I missing something in that analysis? Feel free to critique it.
Well, no, I think I understand your analysis. When we started this process following the RFP, the revocation of the RFP, we really were focused, as was said prior, on really accomplishing several goals: maintaining the high quality and standards that you've had in place for a number of years, and doing so at a fiscally sustainable user rate. So when we began discussions, part of the discussions were around how can we take costs out of the system that don't necessarily have a direct impact on the patient care that we provide. So one of those discussions was around the liquidated damages. The current contract requirement is staying the same at 90% by zone. The changes are around the response time incentive. Several years back, with one of the earlier amendments prior to my arrival, there was an amendment that it eliminated the liquidated damages if the 92% threshold was met. And that was a change, as I said, that was made several years ago. As we've gone over the course of the year, the performance has stayed at the 92% by and large. There have been a few months here and there because of some extenuating circumstances where it might have dropped in a zone or two below 92%, which has resulted in those liquidated damages that you speak of. The liquidated damages, over 85% of them are in the low range. Most of the time that we're late 1 minute or less. So most of them are in that range. Rather than roll those fines into a future rate increase that the user would have to pay, the decision was made with staff in our negotiations that we would not encumber the rate with those increases, but we would rather keep the 92% incentive, which is in the 7th Amendment, but do so in a way that rolled the county response times up as one. So we still have the contractual requirements at 90 by zone to protect the equity amongst geography. That hasn't changed. But what we did was we made the incentive that it was 92% countywide. That way, we still have an incentive as a company to perform at that level, but we're not penalized for a 1 or 2 or 3 or a half a dozen call miss that resulted in large penalties that we ultimately would have to roll into user rates.
So can someone tell us what is the liquidated damages then for a failure to meet a zone performance level of 90%?
They are the same that's in the current contract. I don't know, Doug, and it escalates. So there's a zone penalty for missing one zone by 1% or less. Then that zone penalty increases if the performance goes lower, and it is applied by zone. So we could theoretically be out in one zone or all 5 zones and pay an escalating penalty. Back to your earlier question.
And Supervisor Ellenberg wants to chime in here. Please do, and I thank you for your patience, Supervisor.
Thanks. I just want to address this specific point, and then I'll answer all of my questions later. I mean, it sounds generous that you're trying to protect consumers against higher rates by limiting the liquidated damages, but the rate increases are built into the contract regardless. So I don't see the connection of how that would actually potentially benefit consumers and patients. And the flip side of this really is concerning me too, that it's a flat $250.
Well, at the risk of sounding altruistic, I'll say it was a joint discussion between us and staff as we were working at a rate increase. This contract, as you know, previously described, had to be amended. Part of that amendment involved a rate increase. There was a desire by both parties to keep the rates the lowest in the Bay Area. So that was part of where we arrived at this situation where it was important for the county EMS agency and the county executive's office to maintain a performance incentive for the contract, which is why we maintained the 92%, and not lower the contractual requirement, which is at the 90% by zone.
Maybe I can,
Negotiated piece, essentially.
maybe I can
Thank you.
jump in from administration's perspective. We were very conscious of the desire to make sure that every dollar that was spent by a provider or by a third-party payer or by a constituent actually provided value to the constituent. And the escalator values that you talked about, Supervisor, of $15,000 per individual missed time were, in our mind, not providing any value to the customer or to the individual being picked up, because actually it didn't provide any significant real incentive to change performance, obviously because the people driving the ambulance didn't get the penalty. What happened is the penalty got wrapped up later, months later, into the contract. And so we saw evidence of that when we went through the RFP process in 2018, in which we continued with the same penalty structure, and we had 4 ambulance companies express interest in bidding, but once they tried to pencil it out, they realized that they couldn't make it work, and we ended up with only 1 ambulance company actually bidding, and they bid a much, much steeper rate. So that made it clear to us, an administrative perspective, that our contract proposal, as was proposed in the RFP, was extracting money not for performance but actually for convenience, and was going to raise the rates significantly.
Well,
so since we knew that, and since we knew that we would be doing another RFP, we elected to make sure that, you know, we kept the rates in a reasonable way, in a reasonable manner, and therefore we can have the freedom of doing another RFP, which will be starting within the next year.
That being said, Mr. Wagner, I understood what you said, which is that the fines would just end up in higher rates for the customers in the contract, but I think that what I heard Supervisor Ellenberg saying is consistent with my own assessment, which is once you've got a contract, then you have some incentive to avoid the fines, and those fines are not going to be added to what the customer pays. They're going to be the incentive to you to get there on time. So I don't find that argument persuasive. And you know, just so people know, it's not a question of $250 versus $15,000. I'm looking at page 12 of 39 from the existing contract approved December 7th of 2010, and then subsequently amended, as you've indicated. And so if you're late up to 2 minutes and 59 seconds, it's $250. But then it goes up to 500, 1,000, 2,000, 5,000, 8,500, 10,000, 15,000, based on whether you're late 4 minutes and 59 seconds or 9 minutes and 59 seconds. And the point I was trying to make earlier is there is therefore some very real incentive for people to get there on a timely basis. So when you tell us that, hey, people are, you know, if we're late, we try not to be that late, it's a minute or so, I believe that, but I believe that that's not only because you're trying your best, but because there's some pretty clear incentives to avoid those higher penalties for late arrival. And I'm sitting here still, as I said, wondering how are we going to feel confident that you're going to continue to arrive on a timely basis if there's no real penalty for doing that except the $250, which, you know, you could be, you know, if $3 million is the benefit that's coming to you, and I have no assurance that it is, and I don't mean that skeptically, critically of anything, I just mean we need to parse that number a little more carefully. You know, you could be late 1,000 times, and you could be as late as you wanted 1,000 times, and that's $250,000, which, isn't a lot in the context of a contract this size, and certainly with an increase of $3 million. And then I'm further left to wonder, as I look at the proposed amendment, it indicates that the per call liquidated damages will only accrue if system-wide, all zones combined, compliance is below 92%. So you don't even, as I understand the proposal, Mr. Marquez, they don't even pay the $250 fine if they're managing on average to stay above that 92% level on a countywide basis. Do I understand that right? That's item 9, 4.42, page 4 of the 7th Amendment. Anybody?
Yes, that's correct.
So what that means is that even the relatively modest $250 amount doesn't end up getting paid and doesn't end up costing anything if you make it somewhere else, which I understand, we're looking at big picture countywide, but if I'm the guy who needs to be to the hospital like that for a life or death emergency, understanding that not all calls are life and death emergencies, but if I'm the guy who needs to be at the hospital for a life and death emergency, the fact that it all averaged out countywide isn't giving me any help. And there's no penalty for being later. Am I missing something, Mr. Marquez, in terms of how this is structured? Because I was already anxious about that $250 number, but I'm even more anxious now that I know that you can neglect one end of the county to the benefit of the other, and as long as you hit your 92% number, not even pay the $250.
There's also, as I'm looking at the 7th Amendment, the liquidated damages for monthly zone non-performance. So by zone, there's some pretty healthy incentives to perform. So for example, if in any one zone, if you fall below 90%, if you fall to 89%, it's a $10,000 liquidated damage. 88%, it's up to $20,000. It goes up to 30 and 40 and 50,000. So those are also by zone, sort of an additional level of protection to ensure performance.
They are, but those zone numbers are not at the 92%. They're at the 90% level, which means you've set yourself a lower threshold for zone compliance. And still, even accounting for those performance numbers and the penalties under zone performance, we're still looking at only a $250 flat fee, as I've said 2 or 3 times now. And we're still looking at having that be eliminated if it balances out on a county-wide basis. So the only penalty at that point is if somebody drops down below 90%, which, to your credit, I don't think you've done in the last 6 years that I've been on this board, except for those 2 times in 2 zones. So I want to acknowledge that again as a matter of fairness. But what I'm concerned about is whether or not this renegotiation puts us in a position where I can no longer count on that, because that's what I've been able to count on, to your credit, over the last 6.5 years. Well, those are some of my concerns. Now, the major good news, Mr. Marquez, in the presentation that you provided was that, in fact, the information we received previously was simply incorrect, or at least misleading unintentionally, in suggesting that there was going to be a stopped clock for the AMR rural metro provider once the first responders were on scene. So we're clear about the fact that that's not what it is, and we'll see different language actually in the proposed amendment in Tuesday's document, yes?
That's correct. And one other minor amendment you will see is we need to nail down the actual current value of the first responder fees, which I believe is more in the area of 5.9 million, not 5.7, but we're going to nail down that number and get it right in what we bring back.
Great. Now, what I heard Chief Sapien say, and he can clarify if he wants, correct if I'm wrong, is, okay, good news that we won't be stopping the clock for rural metro once I'm going to just kind of call it the fire department arrives. Forgive me, those of you who have other titles. Once the fire department arrives, but a continuing concern from the chief, and I see he's got some of his colleagues here with him, that if you are getting there later for whatever reason, and I'm concerned you're going to get there later because of the lack of incentives to get there timely, if you're getting there later for whatever reason, that means their folks have to stay on site even longer than they currently do at present, and that then works a hardship on their ability to provide services to other folks who need them in the communities they serve. Chief, am I close? Okay, I'm getting a nod. So how can we provide some assurance, if we can, to the chief and his counterparts that that's not going to be the case?
Well, I think the assurance has been in the last several years, as you pointed out, Supervisor, of our performance. So the plan is not to change any of our deployment methodology, to change the plan and how we move ambulances around. The entire point of this amendment is to recognize that from time to time, there are periods, whether it's weather-related or call spikes or special events that happen, that may strip resources unexpectedly out of the system that cause us to fall below 92%. And when that occurs, there is a significant financial penalty that's paid by the organization that isn't affecting ambulance. There's nothing we can do to have got that to those calls any quicker. It is a fine that's levied, as Dr. Smith said, several months later. So rather than take all of those fines over the years and factor that into a rate increase under this amendment and continue to pay that money, because again, operationally, there's no change we can make, we felt it was better in concurrence and negotiations with staff to say, let's continue to monitor. Let's continue to report like we do on a daily, weekly, and monthly basis to the EMS office and track those response times and make the adjustments that we've made over the years as we see different service pressures, moving those ambulances around, and keep the rates low, while at the same time not completely abandoning the 92% goal. Right? The incentive, I believe, is what it's called in one of the earlier amendments. So the idea was to maintain the incentive, maintain it in a way that's manageable for us so that we're not spending money for no reason, right, through paying fines for an operational fix we can't make. Let's focus on leaving the deployment the way it is, making the changes and improving the system like we have done since the beginning of this contract.
I'm not sure I agree with many of your assumptions, but I'm going to let you make your case and respect that. So, Mr. Marquez, one of the things that we used those fines for was to make incentive payments, and I can never keep Annex A and Annex B straight in my head, but we made payments then to local departments in order for them to stay above the 90% timely response rate, which, if I remember correctly, was 7 minutes and 59 seconds in most venues. And presumably, those incentive payments, do they disappear under this contract? They don't. So where are they in this process? It sounds to me like they are to be negotiated in each case. Is that right? In each jurisdiction, Dr. Smith? Somebody?
Yes. The fees that you're talking about are roughly called the first responder fees, and they have two A and B separations, which we can go through, but basically one of them is sort of a fixed payment and the other one is a performance-based payment for only the first responders. The contract that allocates that is between the first responders and the county, and as we said during Miguel's presentation, that contract doesn't change unless the first responders negotiate a different separate contract directly with AMR. So we will still continue to pay the A and B fees, and that this doesn't impact that at all.
For the moment, it does not, but presumably it will if and when the individual departments negotiate their own new deals, yes?
Right. If they negotiate their own new deal, then our contract with them is canceled, and then they have a direct relationship with AMR. And part of the reason that we felt that was important, as was pointed out in the overhead, is that some of the jurisdictions have ambulance equivalent cars that they have expressed an interest in using, and there is the possibility of having negotiations between those entities and AMR such that those cars, they're essentially ambulance equivalents, can be utilized as part of the response time and presumably be reimbursed through the AMR contract.
Let me interrupt you for a minute because I don't want to lose this thread, and then I want to go to Supervisor Ellenberg. My concern, and the reason I'm raising this question, Supervisor Ellenberg, is that I got to know some of these good people back in 2013 and 2014 when we discovered that local first responders, fire departments, were not able to meet that 90% threshold and get to folks on a first responder basis by 7 minutes and 59 seconds. Now, there was great debate, much of it quite political, about why that was, whose fault that was, what the reasons were. But the whole point of having this program in place was to make sure that we could give incentive fees payments to local first responders when they performed well, because that then gave them an incentive to get there on the quick, just as we wanted to have incentives for the ambulance to get there on the quick. My concern is that if those payments go away, that there are then no longer the same financial incentives for these fire departments or their counterparts to get there on that timely basis. So I don't know how we ensure that or guarantee it, but it needs to be something that we are mindful of going forward, because if AMR and the local providers end up cutting a deal that works for both of them, but that doesn't involve the same timely response, then we will have not served the public well in that regard.
Well, let me try to clarify. The contracts that exist between us, the county, and the first responders, independently of AMR, do not go away unless the first responder communities or, districts contract directly with AMR. So those commitments to pay those fees are still held and will still be respected by the county, and we'll still pay them, and they will be paid out of the franchise fee rather than out of the penalty fee.
But for the record, they could disappear 2 months from now and there wouldn't be a darn thing we could do about it. Because if that's what the negotiated agreement says between the first responders and AMR, we're out of the picture.
Well, if the first responders negotiated a deal where they removed their performance requirements, yes, but we would have to approve that deal because the language in the contract extension requires the new contract to be approved by the county, and we would certainly not approve that.
All right, thank you. That's a public commitment that I think is important to get
Yeah,
into
we
the
would
record.
not approve anything where, a first responder was trying to decrease their performance. That would just not happen. I mean, legally it could happen, but it's not going to happen because we won't approve that from a regulatory perspective.
Supervisor Ellenberg, thank you for your patience with my long line of questioning. I want to make sure you get an opportunity here before we lose Dr. Smith.
Thank you. I want to follow up on that piece too. I think along with the clock stopping, another issue that the fire chiefs did not feel clear on, and nor did I during the last board meeting, was that the contract between those entities and the county is not in fact going away immediately. That was the impression at the board meeting. And I have concerns about the individual negotiations because we have, if I'm understanding correctly, sort of a fixed pot of money, that $5.9 million. If the contracts, if the fire departments individually do negotiate contracts and they're doing them piecemeal, one then another, does that not disadvantage any department or district that comes in towards the end once other contracts have been created? And does that also not muddy the oversight system and timely response system if we've got some departments responding accountable to the county, others directly to AMR?
Good question, and the overall answer is no, it's not an advantage or disadvantage. Actually, it is an advantage because, as we said, if the first responder districts or cities do not enter into a contract with AMR. The current contract expenditures continue, so the districts could decide right now we're not going to bother and everything stays the same. So they're not disadvantaged financially at all. That means that the only thing they can get from negotiating with AMR is a better deal for themselves. And that was intentional. Now, of course, we didn't, publicize that because we didn't want to make it clear to AMR that they might get hit up for more money than they already putting in. But since we're asking these questions in public, I'm saying that they can only get a better deal out of doing a contract directly with AMR. And forgive me for not making it clear to the districts, but a big part of what we heard during the RFP process was the desire that the fire chiefs had and the city managers had to have more control over their component of the structure. And as I mentioned, these ambulance equivalent cars in some districts, but also the fire chiefs looking at a, quote, public option. And this amendment allows them to do that because it's a non-exclusive amendment. So if they can put together a public option that works, that can be done, whereas a continuation of the old contract would have precluded that. So we were trying to give as much flexibility based on the input we got during the RFP process, which was extensive. And, I acknowledge Supervisor Simidian's comment that for reasons that you can blame me for, it wasn't communicated effectively to the police chiefs and the city managers that we were trying to carry their water for them.
Well, to that, Dr. Smith, I think the missed opportunity wasn't simply that you didn't communicate to them, but that there was no collaboration with them so that they would have had the opportunity to speak for themselves, to confirm that, yes, what you were thinking was on the right track, or no, you had misinterpreted. And I would be interested in hearing from Chief Sapien again, given some of the clarity that's been provided here regarding response time and contracting with AMR versus the county, the communication issue aside, because I think we're clear that we can only remedy that going forward. What is your assessment now of what the contract looks like?
Well, I think there's some things I still don't understand in terms of we are presently have a contract with the county expiring June 22nd, 2022, or excuse me, June 30th, 2022. And somehow in this other agreement that we're not a party to, the provider is to contract with us. I won't be the one figuring that out. We'll probably have counsel do that.
It sounds to me, and correct me, and also please continue to ask if it's not clear, that you or any chief could so choose to utterly ignore this opportunity to directly contract with AMR and continue through June 30th, 2022 in exactly the same relationship with the county that you have now.
Correct. That is correct. The language is very specific that until and unless there's a contract between AMR and the cities or the districts, the current contract stays in effect and in place. So the city can just rely upon that contract with the county that lasts until 2022, and nothing will change.
Excuse me, Supervisor, I see that Mr. Williams is leaning in. Mr. Williams, and then Mr. Marquez.
I just wanted to point out, I don't actually think this particular piece is ambiguous at all. If you look at proposed paragraph 3.5.2 on page 2 of the amendment, it says that pretty expressly, that until there are agreements with all of the first responder agencies, the county and rural metro shall continue to allocate and distribute first responder fees in the manner but they were allocated and distributed prior to July 1, 2019.
That's different than what I thought I understood earlier, which is that contracts between individual agencies could be negotiated sort of piecemeal, and they would peel off from the county one by one.
They need to reach agreement with all of the agencies to change the allocation. They can negotiate individual agreements one by one at a time, certainly.
But they don't go into effect until everybody has agreed? So if that's,
Yes.
okay, that's changing my understanding now.
Yes.
So one holdout could render this whole possibility of individual contracts completely moot.
With respect to allocation distribution of the fees, yes.
So it sounds like being the last person to negotiate your contract is a pretty powerful place to be.
Well, maybe, maybe not, but depends on what AMR's available pot would be. But
Right. Supervisor, I want to let you continue to explore this, but before we lose track of this item, I would just say this. If we're having this much confusion at the Health and Hospitals Committee meeting, after this was already an agendized item, clearly we need to refine our understanding here and make sure that everybody is on the same page. So if we could just ask the staff and the county council to address this specific issue specifically and clearly at our meeting on Tuesday, June the 4th, I think that would help provide everyone with some greater assurance. And if there's an opportunity, and there may not be given schedules, between now and that time for our county staff to communicate with the chief and his colleagues so that they reach some mutual understanding of what they think this thing does or doesn't provide and who has what options, I think that would be a helpful step as well, rather than have the same debate play out again next week for the third time in just a couple weeks. Can we ask staff to provide that specific clarity?
Surely we will.
Thank you. Supervisor?
And are there other uncertainties that are remaining for you that we can address?
Yeah, I'm afraid our operational concerns continue, which is we don't know because we weren't involved in the construct of how our resources interrelate specifically with the new response time standards for AMR Rural Metro. We have no idea on the impact to our resource network. And so we view this as a significant change, an actual change in the model of how we provide services. And so the impacts cannot be predicted without really studying the issue.
I share that concern that the incentives given the conversation that we had a few moments ago with AMR, I am also concerned about the response times, and yes, that could impact you. You asked about the worst case at the very beginning of this meeting. So worst case would be that the board doesn't approve the contract on Tuesday. And if that were to happen, do we then no longer have an ambulance service because the piece of the contract that would have continued through June 30th, 2022 goes away as well?
County Council?
I think there are some significant legal risks that are best discussed in an attorney-client privileged manner.
Okay.
That doesn't preclude me from chiming in, which I will. What I've been told today, and I just want to be very clear with everybody, my goal is not to gum up the works. My goal is to get a good result that everybody understands and everybody can work with. That being said, we were told earlier today, Supervisor Ellenberg, I know you heard the same thing I did, that we gave notice on April the 29th, that we then extended the agreement, that agreement will take effect on July the 1st, and then the question that has been raised is, would we be out of compliance in the contract by virtue of the fact that we're no longer in a position to offer an exclusive agreement? And that's my understanding of our legal position, which the council may want to correct, clarify, confirm, remind us we should do some of this in closed session. Let me go to council before I go to you, Dr. Smith.
Yeah, I would just say I think there are other legal concerns that we will share with the board in an appropriate mechanism. Got it.
Thank you.
Ms. Ellenberg, before I go back to Dr. Smith?
Nope, go to Dr. Smith.
Dr. Smith, thanks.
This question comes up and addresses the process question you asked earlier that I'd like to respond to.
Please.
As was mentioned, we went through an RFP process in 2018, at which point we had lots of input from all of the fire chiefs numerous times. And the process of doing an RFP for this type of service requires that the state approve the actual RFP, and then the RFP be put on the street, and then the state has to approve a emergency operation plan and effectively then approve the selection process. We were led to believe during that process that the state would continue with their antitrust immunity transfer to us in order for us to complete that process. However, after long months of negotiations with the state, it became clear that they were going to take action to withdraw the antitrust immunity, and that we could not do anything that would preclude that. So effectively, without getting into legal issues, administratively, we realized that they had effectively precluded us from extending the current contract pursuant to the way it was written. And that's how we got to this point where we had our own ability to extend the contract changed by another party that we didn't have control over. So we felt administratively the best action for us to take was to follow through with the actual specific language on its face of the current contract, which meant giving notice of extension, but also negotiate at the same time an amendment, which is why we come to you with an amendment. And I'll leave it to County Council to tell you what happens if we don't do that.
That being said, as I look at the Seventh Amendment language and the recitals contained therein, recital H in the document provided to our board by administration says that it was in 2017 the California Emergency Medical Services Authority, EMSA, notified the county that the original EMS contract as revised contained significant deviations, and as a result the EMSA has rescinded its approval of the county's EOA. Now, I don't know when it was in 2017, but that means that it's been at least a year and 4 months since we had that information, which is why it is so troubling to me that we are having this conversation in May and being told if we don't act in June on short notice that we're gumming up the works, because it's been at least a year and 4 months since EMSA gave us that notice.
Well, Supervisor, the board was notified of that both privately and publicly. That's why we did the RFP in 2018. We made it very explicitly clear that that was the statement that we got from the state, and that the state said that if we did another RFP, they would rescind that action. At the end of the RFP, they did not rescind that action, and we let the board know that also.
And
so
having been notified of that, Dr. Smith, my point is still the same point, which is we shouldn't be a year and 4 months down the path and having a last-minute jam of the board and being told if you don't take action, you're putting 2 million people at risk. That's my concern, is that just as you've indicated, you had all these conversations, you provided this notice, but somehow when it came time to say, here's the Seventh Amendment that was negotiated at the staff level without the broader participation and not run through this committee, all of that suddenly put us in a position where we're up against the wall. And I'm just saying that would have been a great conversation to have had 2 months ago, 4 months ago, or 6 months ago. But this bringing stuff to us at the 12th hour and putting the board in that position where we effectively have lost our decision-making authority as policymakers by virtue of the untimely arrival is the thing I'm expressing concern about. I'm not expressing concern about the notice that we received. I'm expressing concern about showing up at this particular time in this particular fashion. and we can just have a different take on it, if you like.
I respect the board's belief and comment, and I can only say we won't do it again.
Thank you. Supervisor Ellenberg, continue, please.
I just want to make sure I've heard all of Chief Sapien's concerns and comments.
I think finally what maybe I didn't express clearly is that it is the position of the county chiefs that we are present and available to have substantive discussions about the construct of our emergency medical services. We believe we are a critical stakeholder, and we are always available to continue the discussion.
I'm very glad to hear that. And I'll just note the failed RFP process ended in June of 2018. Just looking at where we are, and I think we have talked that one to the ground.
So what might be appropriate this time, if you're amenable, Supervisor, is a motion to forward to the Board of Supervisors without recommendation on the contract amendment itself, and to direct staff, per your and my previous comments, to provide the additional information that was requested, and to schedule quarterly reports to this committee on both the status of contract implementation, if and when we go forward with a contract, as well as RFP preparation going forward.
As well as response times and status of any negotiations with individual districts.
In those quarterly reports, you're saying, yes?
Yes, thank you.
Yeah, thank you. Is that a motion?
That's a motion. So moved.
Dr. Smith?
Mr. President, I request to be excused because I have a doctor's appointment.
Understand entirely. Thank you for staying with us as long as you did, and a very helpful meeting indeed. We have a motion by Ellenberg, a second by Simidian. I don't think we have any more speaker cards. We do not, says the clerk. Any additional comments? We haven't numbed you all beyond. Then, without objection, hearing none, the motion carries 2-0 unanimously. Thank you all. Mr. Wagner, thank you again. Very helpful, Chief. Thank you again. Thank you to all of you who are here to help us make our way through this complex and challenging set of issues. That takes us to item number 7, which is to receive the report. And why don't I turn to Mr. Lorenz for that report.
Thank you, President Simidian, Supervisor Ellenberg. We are 90 days into the integration of the hospitals. Overall, we continue to make steady progress in integrating the 3 hospitals. Patient volumes and hospital census remain steady with some seasonal variation, while deliveries and surgical volumes at O'Connor and St. Louis are lower than expected. We continue to actively work on contracts and recruitment opportunities to rebuild those service lines. I would also add that we continue to have success in the managing of patients within the 3 hospital system that require a higher level of care, whereby 86% of the requested transfers have remained within the system. And only those patients that require a higher level of care are being transferred from the system. Efforts are also underway to leverage the additional capacity to further improve wait times for specialty and elective surgical cases by coordinating referrals with community physicians to utilize the capacity at both O'Connor Hospital and St. Louis Hospital. We are also on target for the August 17th go-live of HealthLink. This includes the development of the technical infrastructure and the network, as well as the acquisition of end-user devices. We are looking to begin training in July for all end users and staff, including community physicians. That's 30 days away, and I'm very pleased to report that the HealthLink team and the staff have done an outstanding job in preparing and looking toward that go-live date of August 17. We also continue to work closely with ESA on the recruitment and the transition of staff from provisional status to permanent status. HR has opened 29 different recruitments for the clinical nurse series at O'Connor and St. Louis Hospital. In that, we have received, as noted earlier in previous board meetings, that we have received 5,400 applications. Of those applications, 3,800 plus are in the clinical nurse level 1 series, which are new nurses, and then approximately 1,500 are in the Clinical Nurse 2 and 3 series, which are experienced nurses. We have received 470 provisional applications from provisional staff from the 2 hospitals. So close to 100% of the staff nurses have applied for positions with the county to maintain their current work at the 2 hospitals. HR is currently reviewing the applications and developing a certified list. It's 5,400 applications for which they are reviewing, and we're looking to the month of June to begin reviewing those certified lists, and the managers will begin to hire staff on a permanent basis. We are also in the midst of 17 county-wide recruitment efforts, which includes food service workers, janitors, analysts, and other support staff. So with that being said, I would be happy to answer any questions. Of course, in your package, you do have our detailed integration report.
Thank you. I do not believe we have cards on this item. Supervisor Ellenberg.
Thank you. Paul, it's really impressive that the team is accomplishing so much and is able to stay on the original timeline so far. So really kudos to your team for that. There's some metric information that I've been asking for a couple of months that I really want to see in the future reports. You referred to these generally, but some specific metrics related to employee integration, like the number of codes that have been posted, number of employees that have transitioned from provisional to regular hires would be helpful so that we can really measure a little bit more precisely how well we're doing, how much we're on target towards those. And then I have a slightly different question, but goes to employee benefits. A D4 constituent reached out to me who's at O'Connor Hospital. Her son has a life-threatening illness, and because of the transition and the equity introduction, I don't have the right word, that all employees came in without seniority status. She doesn't have access to FMLA, and I'm curious to know what we are doing in general with new employees that have gone through this transition, and if the new employees aren't eligible for family leave under FMLA, they can, I understand, request leave of absence. That's not necessarily a consistent process, and I'm wondering if you have data or can get us data on how many of these type of requests we've had, how are they being tracked, are employees getting the relief that they need, and how do we anticipate addressing this going forward without the seniority levels?
Thank you, Supervisor. David Manson from HR is here, and I'm hoping that he will be able to answer your question. If not, we can return with a specific response to your question.
Great, thank you.
Good morning, Supervisor. Dave Manson, Employee Services Agency. You have a couple of questions there. I think one of them is it's not the seniority that the employees need to have to qualify for FMLA. It's actually the
time worked.
50 hours. Correct.
Right. I'm sorry, I misspoke, but thank you for understanding.
And so the employees are still able to go on leave should they desire. It would be a health leave, would be an unpaid leave because they don't have any balances to integrate with. But they're still eligible to go on leave if they so desire. We're not aware of anyone that has requested a leave and has been denied leave from that perspective. One of the things that I think you'd ask about was the number of employees that came on board and then went on out on leave. So we know the information we got from Verity was kind of sketchy in terms of the actual numbers and statuses of their employees that were on leave and their employee status. But we know that there have been 25 employees that have returned from leave and are now currently employed with us.
What about, first I want to note that being able to take leave but having it not be paid is clearly a hardship and may prevent people from taking advantage of that. But I'm thinking about also issues that have arisen since people were hired, so that the time has not yet accrued for them, family emergencies, maternity leave, or other needs. You said that nobody has been denied a leave request, which is good to hear for those that could afford to take it unpaid. How many people have requested those leaves, and do you know what categories they fall into? Maternity, emergency?
I don't have that information specifically at that level. I do know that currently there's 11 individuals that are on leave at St. Louis, and there's 3 that are on leave based on our information at O'Connor.
All unpaid?
Yes. Yes.
Is there any relief or support that we can give people in truly emergent situations who demonstrate that they cannot afford to take this time unpaid? Can we pay it forward or work with individual employees at that level when the circumstances appear to warrant?
Not that I'm aware of, Supervisor. We can take this back to the ESA Benefits Director and discuss that with them.
I see Mr. Lorenz leaning in. I just want to give him an opportunity to.
Please, yes.
I think David answered that correctly. I think what we need is time to go back to ESA and look at the collective bargaining agreements and look at what flexibility we have.
All right.
Is that something that could be accomplished by our next meeting in June?
Yes.
Yes.
It's actually something that I might like you to follow up with off agenda, if for no other reason that I can specifically address my constituent with what the rules are and what her options are, and we can certainly talk about it more generally as well at the next meeting.
We will be sure to get back to you as quickly as possible.
Thank you. I appreciate that. That's all I have on this item.
Thank you. No need to bring it back then to committee. I think we'll simply ask for an off-agenda report, which could then be the basis for any individual supervisor to follow up. But the off-agenda report sometime in the next 4 weeks. Does that work?
Understood.
Great.
Supervisor, if I may,
Please.
just to add, I think an important point I want to be clear on is I understand it, FMLA is not paid leave, and any paid leave would come through a collective bargaining agreement or something like that. That's why we need to go back and look at it. But FMLA itself is simply a federal job protection for a period of time, but it doesn't include paid leave.
Right, that's correct.
But they still have to accrue a certain number of hours before they can take advantage of that.
Before they can take advantage of the job protections afforded, I think it's for 12 weeks under FMLA.
Okay. I'll take it up more offline. Thank you so much.
Great. Thank you. I have no questions at this time, just mindful of the hour, not a lack of interest to assure you all. So if we can get a motion to simply receive the report. Thank you. And then without objection, so ordered. Before we go on to item number 8, Supervisor, and folks who are in attendance, I'm going to say thank you, but I'm also going to just exercise a point of personal privilege here. Sitting in the back of the room is Tyler Haskell. Mr. Haskell serves as my chief of staff and has been the lead for the last 6 years here at the county on health matters for me. Mr. Haskell has worked with and for me both in my state Senate office and at the Board of Supervisors for more than 10 years now. He has received a wonderful offer to go continue his good works in a different venue, and that would be with the Santa Clara Family Health Plan. So before he has a chance to step away from what will be his final committee meeting in this role, I just wanted to express my personal thanks. He's done an extraordinary job for me personally, for my office, and most importantly for the people that we have represented. And thank you again for that. I wanted it to be acknowledged in public. So yes, we can give him a round of applause. All right, thank you. If you are sufficiently embarrassed now, Tyler, we will move on to item number 8, which is to receive reports relating to emerging issues regarding the County of Santa Clara Health System. I do have a card on 8D. I think what we'll do is do 8B and C and then go to the card for 8D. So, verbal report from the Director of County of Santa Clara Health System.
Yes, Mr. President and Supervisor Ellenberg. Very quickly, a couple items that I just wanted to give you an update. We're still meeting with the community clinics. We've gone through the majority. We're listening to the very specific clinic issues. They've given us the information in terms of how they're doing. They seem to be doing better than the initial testimony when it was here, and that's encouraging because obviously that means we're serving more clients and patients and residents of the county of Santa Clara. And it is the intent of our county executive, Dr. Smith, to come back with a set of recommendations as part of the recommended budget. The second piece is related to questions on custody health. I know this is Supervisor Ellenberg. We provided 2 off-agenda memos that I just wanted to put at notice. And then, of course, this is just an ongoing piece because obviously the chronic vacancy issues as well as the workload demands now on the workforce as a result of increasing demand for care and services will be something that we're going to have to deal over the next several months. So just wanted to give you that update. Thank you.
Thank you very much.
Just make a very brief comment, and in fact a repetitive one. Want to emphasize again that I would really like to see these monthly reports include public health, EMS, and custody health as well. But thank you very much for what is provided here. It's very helpful.
Thank you.
Takes us to 8B, which is the report from our health officer.
Good afternoon. I'll just make this quite brief. I wanted, mostly because Pam Stoddard had shared the congenital syphilis slides, and I know that's an interest, to give you a little bit of a more granular update, which is that in 2017, we had 19 women who were pregnant with syphilis, resulting in 7 congenital syphilis cases. In 2018, 25 women who were pregnant with syphilis, however, only resulting in 4 congenital syphilis cases, and that's largely because we redirected a lot of resources away from individual follow-up with men who have sex with men towards women. We obviously have a lot more work to do, and I just again want to reiterate that what we're seeing in our county is being seen in many jurisdictions across the state. We are by no means alone. I guess I'll just give a little update. Tyler, I'm sorry to see you leaving. I had no idea. In the public health department, we're also going to be having a lot of changes, particularly on our executive team. We have a number of retirements and people moving on, so we'll have a lot of change this summer. I won't detail it for you, but no emergencies for the summer while we're in transition.
All right.
All right, so it has been so declared.
Duly noted. That takes us to 8C, which is to receive the verbal report from the Chief Executive Officer of Valley Medical Center. Anything additional, Mr. Lawrence?
Supervisor, no, I do not.
Thank you. That does take us to 8D. Is Mr. Largent still in the room? He has a card to speak. If not, why don't we just go directly to the report. 8D, and Ms. Tully's, I believe that's you, Behavioral Health Services.
It is me. This is a brief report at your request. I think the most positive news that I'd like to share today is for the last 3 weeks, all individuals calling the call center wanting services have gone directly into services, both in family and children and adults and older adults. That's a direct result of the increase in the work by the contract providers, and that's something we should all celebrate.
Thank you.
And I know Supervisor Ellenberg, you asked for some specific information about the contract providers, and I have lots of numbers for you, but just in essence, we have 49 mental health contracts representing 232 programs. All of the contracts, both in mental health and substance use, are being finalized right now. We're working really closely with all of the providers. Those contracts will go through with a delegation of authority provided to us at the board. They'll be signed the beginning of July. We met yesterday with all of the executive directors for the Behavioral Health Contractors Association, so things are moving along as planned.
Thank you so much for your attention to that, and also wonderful news about the mobile health crisis clinic van as well. The early numbers are really impressive and encouraging.
Thank you.
And let me express my thanks as well for the cooperation and collaboration on Headspace, particularly the North County facility, which we're hoping to stand up sooner rather than later. And we have a group of people who are working collaboratively in the county organization to make sure that everybody's working hand in glove to get to a good result sooner rather than later. So thank you for that. That takes us then to item 8E, Valley Health Plan.
Thank you, Supervisor Simitian, and I would just defer to any questions that the committee might have.
None today, thank you. And that takes us then to 8F, Federal Health Policy and Budget Landscape. Mr. Margolin.
Good afternoon. Just a few items to update you on. Up until last week, the federal budget process was moving relatively smoothly. It was last week that the Speaker and the President had their confrontation, and we're now in a situation where the President's saying that he's not going to cooperate with the Congress. We don't know how long that will last and what implications that will have for the budget process. But in the budget process, there are two funding issues of particular concern. We still are concerned about the DISH cuts that are scheduled to take effect September 30th of this year. There's $30 million at stake for Santa Clara County in the first year of those DISH cuts, and then that amount doubles in the second year. There's also $4 billion nationally, a smaller amount obviously locally here in Santa Clara County, for community health centers in their grant funding that needs to be reauthorized. So we have these two funding sources that we're very concerned about, even though we've had some disruption in the budget negotiations because of the events of the last week. It is still very likely, because of the bipartisan support for deferring the DISH cuts and for supporting community health centers, that these items will, in fact, be resolved before the year is over. There are four health issues, four major areas of engagement on health issues in Washington to very briefly touch on. Democratic efforts to repair the ACA continue to move forward. The House passed a bill within the last 2 weeks to restore the marketing money to deal with the short-term health plans, the so-called junk health plans, moving out of the House to the Senate, where it's very unlikely that any action will be taken, but the Democrats in the House continue to move forward on repairing the ACA. They also are continuing to look at the single-payer issue. Congressional Budget Office came out with a report, which they received on the House side at a recent public hearing. Again, no action on single-payer is likely, but they continue to debate that issue. The third item is an item that there is bipartisan interest in and the likelihood of some action, and that's lowering the cost of prescription drugs. There continues to be this bipartisan agreement on dealing with generic drugs, getting them to market more quickly. The House recently passed a bill that would deal with this generic drug acceleration issue. There is an internal debate among House Democrats about the other piece of this pharmaceutical package, and that's the issue of negotiating with the pharmaceutical companies for lower prices. How do you go about doing that? The Progressive Caucus wants everything in Medicare Part D to be subject to a full, across-the-board negotiation with Health and Human Services. Speaker Pelosi just last week put out a more modest proposal that would address the 25 drugs at a minimum each year. It's a more limited approach. Some of the highest cost drugs, the idea would be to negotiate with the pharmaceuticals on these 25 drugs, high-cost drugs, and that if agreement was not reached, there'd be a GAO intercession. They would actually resolve the issue and be the final judge of what the price should be. So it's an aggressive regulatory move by Speaker Pelosi, but limited to 25 drugs, a debate within her caucus on that issue. The fourth issue involves that the Congress is engaged in involves surprise medical bills. This is where you go to an emergency room quite typically, and your in-network doctors charge you what you expect, but an out-of-network anesthesiologist or some other specialist who's not part of your insurance plan suddenly sends you a bill for a very large amount of money that you didn't expect. There's really a very strong bipartisan consensus on trying to deal with the issue. California has already dealt with this issue to some extent in 2016 with a bill that Assemblymember Bonta advanced that actually said that if you go to an in-network hospital and there's an out-of-network doctor who treats you, that out-of-network doctor is actually bound to the payment rate for your in-network physician. So it's not a full fix of the issue. They're debating that issue at a federal level now to see if they can catch up with California, and there are other examples of what there are other ideas on the table for how they might go about resolving this issue. The Senate, Alexander and Murray, the two senators, one Democrat, one Republican, who worked together on a bipartisan basis, recently introduced a bill called Lower Healthcare Costs Act of 2019, which incorporates surprise billing proposals, pharmaceutical cost proposals. It's a discussion draft. They haven't come to terms yet with what they want to ultimately do, but they're trying to move together on a bipartisan issue on the Senate side. So that's the federal scene very briefly, and there's only one state issue that I just want to flag for your consideration, for you to be aware of. The 340B pharmaceutical drug program that saves money for Santa Clara County and other safety net providers has some degree of risk as a result of the governor's executive order on group purchasing of pharmaceutical drugs. You know, it's a very important program the governor's trying to advance. There's an unintended consequence on safety net providers in 340B. The advocates for public hospitals and community health centers are working together with the legislature to try to get the governor to agree in this negotiation on budget trailer bill language that would establish an advisory group of stakeholders on this 340B issue that would work with the Department of Healthcare Services over the next several months to actually identify the financial risk to public hospitals and develop mitigation strategies so that the losses that we're currently anticipating can potentially be avoided. And that completes my report, Mr. Chairman.
Thank you. Your speedy delivery served you well on this occasion. Thank you.
Thank you.
Supervisor Ellenberg, any questions? I have just one quick and easy one, I think. Ms. Margolin, you mentioned the dish cuts that are scheduled to occur. We've talked about so many different programs and so many different funding streams. I just want to make sure I remember. The dish cuts are the ones, however, where there's been a bipartisan effort to try and forestall those for some period of time, yes?
That's correct.
And so part of what I should take from your comments a few minutes ago is that when things blow up and people aren't talking to one another, we worry that the autopilot will take us to dish cuts that otherwise might have been forestalled. Is that, am I on the right track?
There's some risk when things blow up, but again, as I indicated, because of the strong bipartisan support for deferring on dish and because there has to be some kind of a budget deal, ultimately, I think our risk is small. It's there, but it's small.
Thank you. All right. Then I think I will say thank you very much for that. Thank you for being with us for this entire afternoon. Appreciate it. And that gets us through the end of 8. And without objection and hearing none, we will deem reports under item 8 received. Takes us to item number 9, which is to consider various budget inventory items and forward to the Board of Supervisors for consideration. These items are really here, for those of you who are unfamiliar with the process, to sunshine them so that when they come up in the budget, they have been heard of before. They don't simply pop up at the 12th hour in our budget process. So I think it's a good thing. We did have one speaker earlier today. Let me just confirm. I don't think we have any other cards from speakers. No? Then in the absence of any comments, Supervisor Ellenberg, and obviously if you want to make comments on anything that's here, I know you've got an item. But otherwise, just a motion to forward to the Board of Supervisors for consideration would be timely and appreciated.
So moved.
Motion by Ellenberg, second by Simidian. Last call. Then without additional comment and hearing no objection, unanimously approved. We have already approved our consent calendar. That takes us to adjournment. And here again, without objection, we stand adjourned. And the current next meeting is scheduled for 2 p.m. here in these chambers on June the 27th. Thank you all. Appreciate your participation and presence today.